Every relapse and refractory AML is very challenging, and especially in patients with FLT3 mutations. And in recent years, however, we have several targeted therapies for specific mutations such as FLT3 that were shown to be effective, and especially in patients who can pursue allogeneic stem cell transplant afterwards. I think my first goal would be, if possible, is to achieve a complete response in any patients with relapse and refractory AML, hopefully an MRD negative response, and to be followed by allogeneic stem cell transplant, and to consider, because we have data about that as well, to consider maintenance therapy afterwards, after the transplant. I think that off trial, the best treatment that I can offer today is based on the Admiral trial is gilteritinib monotherapy. And again, I would try to continue with to pursue an allogeneic stem cell transplant afterwards. And if I can enroll the patient into a trial. So we have several options today, either as doublet therapies that was presented by Dover at ASH 2021 with venetoclax, or by Nicholas Short at ASH 2021 with the triplet of HMA, ven, and gilteritinib, or even now at IA, Ilmaz from MD Anderson presented nice data about patients that were treated with HMA, ven, and quizartinib with high response rates and high MRD negativity rates.